We'll be discussing immediate placement of maxillary small diameter implants at the time of tooth extraction. You can see this gentleman had presented with only 6 maxillary anterior teeth, no posterior maxillary teeth, and had a large abscess on the upper right cuspid tooth. These are before and after photos at the end of the case. You can see I've restored this case with an upper denture secured by small diameter implants. So why take the teeth out and place a denture rather than try to restore them? Doing these complex cases every day, when you finally just run out of teeth, and it's a much more expensive and involved process to save the remaining teeth, even if some of the teeth are okay, like number 10 to right lateral incisor to the left cuspid are okay. So this gentleman decided we would extract the upper teeth, place maxillary small diameter implants, and then restore his mandibular teeth. So this is following tooth extraction. Now when I'm extracting teeth and going to place implants, I try to extract the teeth straight out of the sockets. I don't want to extract them facially, because if I do, we're going to lose the buccal bone. Continuing to remove the interproximal soft tissue with rongeers, and now I'm reflecting the tissue. Now, normally I try to reflect this tissue minimally because I want to preserve the blood supply. In this case, we've got this huge defect over here, and I've got to reflect apical to that defect, so I'm sure all the granulation tissue is completely cleaned out and I can bone graft it appropriately. Now here's something else to think about when you're securing a denture with small diameter implants. It's no different than all-on-4 as far as vertical bone height goes. It's important that you have vertical dimension for the implants and the denture. Removing vertical bone height is not something we like to do, but it must be done if you're going to have a nice aesthetic result if you don't have preoperative vertical bone loss. So that's what I'm doing here. With these rongeers, I'm removing some of the vertical bone. So I'm removing the gross granulation tissue, the bulk of it, with the rongeers. You've got to clean all of that out. Now, in some cases, I would let this heal prior to placement of the maxillary implants. In this case, I was able to clean all the granulation tissue out and felt confident that I could place my small diameter implant in that site at the time of tooth extraction and granulation tissue removal. That's one of the wonderful things about small diameter implants. What if I attempted placement at this time and it didn't work? The implant didn't osseointegrate. It's not the end of the world, because you can remove that implant, since it's only going to be 2.9 millimeters in diameter, bone graft it again, let it heal for 6 months. It's not as big a deal as if you were placing root form implants and lost one, especially in the case of all-on-4s. Now this is a bone file, and I'm smoothing these edges. You don't want any sharp corners or edges. See, I'm really working on this palatal also. I want that to be reduced so that we've got symmetrical vertical height. And use both sides of the bone file. Pull it towards you and push it away from you also. The pushing away really smooths it. One of the reasons I like to place implants at the time of tooth extraction is because the socket tells you exactly where the implant should go. So I'm checking the depth of these sockets because I'm going to place my implants right now, right after I've extracted those teeth. And I would like the implant to extend into the bone apical to the tip of the socket a few millimeters. I can see that's about almost 14 millimeters of socket depth. This is a pilot drill, which is probably 1.2 to 1.5 millimeters in diameter. And I'm going to use that for my initial osteotomy. I'm using the Acceptico unit and handpiece motor to place these implants. I'm also using the dentist's root form implant system. I'm going to use their 2.2 millimeter drill here in a moment because we're placing 2.9 millimeter implants, so you need a little more width with your pilot hole than the width of the pilot drill. So here goes the pilot drill, lots of water. You can see I'm hitting that cortical bone at the apex of the socket. The drill is on the palatal part of the socket. You don't want the drill or the implant coming out this way. You want it that way. This is my 2.2 millimeter dentist drill. And I'm going to take that to the same depth as the pilot drill. Actually, in a perfect world, I'd like the drill hole to be just a little bit deeper than the implant. That way, if you mismeasure just a little bit, I can get all the threads under the alveolar crest. I don't hit a log jam or a stop at the apical part of the drilled hole. So I'm putting this to place, pulling the little cap off. I'm careful to keep these in the correct alignment with the socket if the teeth are where you want the implants to be. If the teeth are in alignment, then that socket is a beautiful guide for implant placement. Now, in the past, small diameter implants have only been used for denture stabilization in a perfect ridge without modification of the ridge. That's ridiculous. Most edentulous patients you see in your office that do not have implants will have knife-edged ridges. So that's one of the reasons that small diameter implants have gotten a bad rap. Dentists are trying to put small diameter implants into knife-edged ridges. Well, remember, a small diameter implant is no different than a wood screw you place in the wall. You want to place it into a flat surface. So you've got to modify those ridges so that they're flat if the patient is edentulous when they present. Here I'm placing the second one. I'm trying to keep these aligned, but another nice thing about small diameter implants is the vertical and horizontal alignment can be off up to 30 degrees from the adjacent small diameter implants, and the denture still seat beautifully. And then come back with the winged or the T-wrench, or you can use the ratchet wrench. You want to screw just about a quarter of a turn and then give it just a second for the bone to expand. Now remember, it's a lot easier to screw implants into the maxilla than the mandible because the bone is so much softer. Now you should not be able to screw the implants into the bone anymore with the finger driver once they're to place. You shouldn't be able to screw them in with the finger driver. It should take either the winged wrench or the ratchet wrench to move them any further apically. That was a collagen membrane that I'm pre-soaking. I'm just taking some of the patient's blood to mix with the Biowas cancellous bone. So you can see how dense that bone is at the apex of that defect. And what I did to clean it out, I used the rongeers, then I used the spoon, then I scrubbed it with chlorhexidine on a cotton ball held by cotton forceps. I just scrubbed and scrubbed and scrubbed so there's not any little tag of granulation tissue in that defect, but you've got to reflect to the apical aspect of that defect to be certain that you've removed all the granulation tissue, especially if you're going to place the implant at the same time. Now, this is Biowas cancellous bone, and you can either mix it with sterile saline or the patient's blood. I'm placing the cancellous bone in all the voids, because obviously when you place the implant in the socket, you want as large an implant as you can place. Then you don't have to fill so much of the extraction site with bone graft. This is a resorbable membrane. You'll see this is soaked for about 5 to 10 minutes and then just place it over the defects. I'm trying to cover all of the bone graft with the resorbable membrane. You can use 4-0 gut or 3-0 gut, or you can use chromic gut. Now, chromic gut is going to resorb in about 2 weeks. Plain gut is going to resorb in 4 to 7 days. And in a case like this, I really only need the tissue to be held in place by the suture for about a week. First, I placed soft liner in an immediate denture that's been fitted to the ridge. And this has been fabricated by the laboratory. Then I'm going to trim that once it's set and place Fixodent powder on a wet denture just in the palatal part. I'm going to wet the mouth real well. This is Neosporin ointment I'm placing over the extraction site and the sutures, and then put this to place and push up in the center of the mouth. Now, I'm not securing this denture with the implants. There's no implants above the tissue to secure it with. Plus, I don't want to place any lateral force on those implants for about 3 months. So this is secured by the palate. So check the occlusion. Should be balanced. I don't want the anterior teeth to contact when the patient bites down into centric occlusion. So here are the implants in place. This is 3 months post-op. And that's today's Dental Minute.
Thank you all so much for tuning in to this week's episode. Make sure you subscribe, and we'll see you next week when we talk about how to perform a frenectomy. You will not want to miss it.